Your cells are making metabolic decisions right now, not consciously or deliberately, but through ancient signaling pathways that evolved over millions of years to respond to nutrient availability. When food is present and glucose enters your bloodstream, these pathways activate growth programs, protein synthesis, and energy storage. When food is absent and glucose drops, they activate entirely different programs involving cellular repair, autophagy, and fat mobilization. Your cells switch between these two metabolic states continuously based on when and what you eat, and the time you spend in each state determines not just your body composition and energy levels, but fundamental processes including inflammation, hormone production, cellular aging, and disease risk. The problem is that modern eating patterns have eliminated one of these metabolic states almost entirely from most people's daily experience. Continuous food availability combined with frequent eating throughout waking hours keeps your cells locked in the fed state for 16 to 18 hours daily, leaving minimal time for the repair and maintenance programs that only activate during fasting periods. This represents a dramatic departure from the nutritional environment in which human metabolism evolved. For the vast majority of human history, periods without food were unavoidable and frequent, creating selection pressure for metabolic adaptations that enhance survival during fasting by activating cellular protection and repair mechanisms. Those same mechanisms still exist in your cells today, but they remain largely dormant when eating patterns provide continuous nutrient availability. What has emerged over the last 2 decades is a surge of interest in intermittent fasting as a strategy for weight management, metabolic health improvement, and longevity enhancement. Intermittent fasting encompasses various eating patterns that cycle between periods of eating and extended periods of voluntary fasting, typically ranging from 12 to 24 hours or longer. Proponents claim benefits including effortless weight loss, improved insulin sensitivity, reduced inflammation, enhanced cognitive function, and even lifespan extension based on research in model organisms. The popularity has reached the point where intermittent fasting is now practiced by millions of people worldwide, often adopted based on testimonials and popular media coverage rather than comprehensive understanding of the underlying mechanisms or the limitations and potential risks. The challenge with intermittent fasting, as with most nutritional interventions that gain widespread popularity, is that the public discourse has become polarized and oversimplified. Advocates present it as a panacea that works for everyone and solves multiple health problems simultaneously. Critics dismiss it as unnecessary, unsustainable, or even harmful, arguing that meal timing is irrelevant compared to total calorie intake and food quality. The reality, as research has progressively revealed, is substantially more nuanced. Intermittent fasting produces measurable metabolic effects through specific biological mechanisms, and these effects can be beneficial for certain individuals under certain conditions. However, the same mechanisms that create benefits in some contexts can create problems in others, and individual variation in response to fasting is substantial. I am Dr. Alex, an emergency medicine physician. Throughout nearly 10 years of clinical practice, I have observed the full spectrum of outcomes from intermittent fasting implementation. The patient whose metabolic markers improved dramatically and whose type 2 diabetes entered remission after adopting time-restricted eating. The young woman who developed severe electrolyte disturbances and cardiac arrhythmias from combining intermittent fasting with intense exercise and inadequate nutrition. The individual whose thyroid function deteriorated and whose menstrual cycles ceased after months of prolonged daily fasting windows. My objective is to provide a comprehensive evidence-based analysis of intermittent fasting that explains the actual biological mechanisms, identifies who benefits and who faces risks, and establishes clear guidelines for safe and effective implementation when appropriate. For the next several minutes, we need to examine what intermittent fasting actually does at the cellular and hormonal level, how these effects translate to health outcomes, and what determines whether those outcomes are positive or negative for any given individual. Once these mechanisms are understood, intermittent fasting transitions from a simple diet trend to a complex metabolic intervention that must be matched carefully to individual physiology, health status, and goals. Before discussing what intermittent fasting does and whether it should be implemented, we need to establish what actually constitutes intermittent fasting and what occurs metabolically during fasting periods. Intermittent fasting is not a single protocol, but rather a category encompassing multiple approaches that share the common feature of extended periods without calorie intake. Time-restricted eating involves limiting all food consumption to a specific window each day, typically ranging from 4 to 10 hours, with fasting for the remaining 14 to 20 hours. The most common implementation is the 16 to 8 protocol, where eating occurs within an 8-hour window and fasting extends for 16 hours. Alternate day fasting involves alternating between normal eating days and either complete fasting or severe calorie restriction, typically consuming less than 500 calories on fasting days. The 5 to 2 protocol involves 5 days of normal eating and 2 non-consecutive days of significant calorie restriction. Extended fasting involves complete or near-complete calorie restriction for 24 hours or longer, sometimes extending to several days. The metabolic transition from the fed state to the fasted state proceeds through several distinct phases as time without food progresses. During the fed state, which begins during eating and extends for several hours afterward, insulin levels are elevated in response to nutrient intake, particular carbohydrates. Elevated insulin signals cells to take up glucose for immediate energy or storage as glycogen, to take up amino acids for protein synthesis, and to suppress fat mobilization from adipose tissue. Anabolic pathways are active, building and storing rather than breaking down and mobilizing. The nutrient-sensing pathways, including mTOR and insulin signaling, are activated, promoting growth and suppressing cellular cleanup mechanisms. As hours pass without food intake and blood glucose begins declining, insulin levels drop and counter-regulatory hormones, including glucagon, begin rising. This hormonal shift signals the transition into the fasted state. Initially, the body maintains blood glucose by breaking down hepatic glycogen stores, which can sustain glucose levels for approximately 12 to 16 hours depending on glycogen stores and activity level. During this early fasting phase, some metabolic benefits begin emerging, including reduced insulin levels and initiation of glycogen depletion, but the major metabolic adaptations associated with deeper fasting states have not yet occurred. Beyond approximately 12 to 16 hours of fasting, once hepatic glycogen is substantially depleted, the body must shift to alternative fuel sources to maintain blood glucose for the brain and other glucose-dependent tissues. This triggers increased gluconeogenesis, the synthesis of glucose from non-carbohydrate sources including amino acids and glycerol. Simultaneously, fat mobilization from adipose tissue accelerates dramatically, providing fatty acids for oxidation in most tissues and glycerol for gluconeogenesis. The liver begins producing ketone bodies from fatty acids, providing an alternative fuel source that the brain can utilize to reduce its glucose requirements. This metabolic transition represents the most significant shift in fuel metabolism and is associated with many of the purported benefits of intermittent fasting. The hormonal changes accompanying this metabolic transition extend beyond insulin and glucagon. Growth hormone secretion increases substantially during fasting, with levels rising by several-fold after 16 to 24 hours of fasting. Growth hormone promotes fat mobilization and helps preserve lean tissue during calorie restriction. Norepinephrine levels increase, enhancing metabolic rate and promoting alertness and focus despite the absence of food intake. Cortisol rises to support gluconeogenesis and maintain blood glucose. The increases in these counter-regulatory hormones represent adaptive responses that evolve to enhance survival during food scarcity by mobilizing stored energy, maintaining lean tissue, and preserving cognitive and physical function. At the cellular level, the absence of nutrients and the drop in insulin signaling activate pathways that were suppressed during the fed state. Autophagy, the cellular recycling process where cells break down damaged proteins and organelles and recycle their components, increases during fasting. This process is suppressed by insulin and mTOR signaling during feeding and activated during fasting when these growth-promoting signals decline. Autophagy provides both energy through recycling of cellular components and cellular maintenance through removal of damaged structures that would otherwise accumulate and impair function. Additionally, fasting activates cellular stress response pathways that upregulate antioxidant defenses and DNA repair mechanisms, potentially contributing to cellular protection and longevity effects observed in animal studies. What becomes evident from understanding the fed-to-fasted metabolic transition is that intermittent fasting is not simply calorie restriction achieved through meal timing manipulation. It is a metabolic intervention that alters hormone levels, shifts fuel utilization, and activates cellular processes that remain largely inactive during continuous feeding patterns. Whether these changes produce net benefit or harm depends on multiple factors, including the duration and frequency of fasting, the nutritional adequacy during eating periods, the individual's baseline metabolic health, and whether the metabolic adaptations to fasting align with or conflict with the individual's physiological needs and health goals. At this juncture, if you are considering intermittent fasting or seeking to understand whether it represents an appropriate strategy for your circumstances, I want to establish a clear commitment regarding the information provided. I will continue producing evidence-based analysis that examines both benefits and risks of nutritional interventions, rather than promoting or dismissing approaches based on popularity or ideology. The request I make is that you consider subscribing to support the expansion of nuanced, mechanistically grounded health information that extends beyond oversimplified recommendations. If you reach the conclusion of this presentation and determine it did not provide a balanced, evidence-based analysis that improved your understanding of intermittent fasting, you are welcome to unsubscribe. However, if you find the mechanistic explanations and practical guidance valuable, your subscription helps extend the reach of this information to others who would benefit from understanding both the potential benefits and the circumstances where intermittent fasting may be inappropriate or harmful. Please consider subscribing now, and we will continue with the examination of who benefits from intermittent fasting and who faces potential risks. The first potential benefit of intermittent fasting involves insulin sensitivity improvement and blood glucose regulation. Multiple studies have demonstrated that time-restricted eating and alternate-day fasting can improve insulin sensitivity, reduce fasting glucose and insulin levels, and decrease hemoglobin A1c in individuals with insulin resistance, prediabetes, or type 2 diabetes. The mechanism appears to involve several factors. Extended fasting periods allow insulin levels to remain low for substantial portions of each day, giving cells a break from continuous insulin stimulation and allowing insulin receptor sensitivity to recover. Fasting also depletes hepatic glycogen, reducing the substrate available for hepatic glucose production and decreasing the glucose load that must be managed. The metabolic shift toward fat oxidation during fasting may improve mitochondrial function and reduce the lipotoxicity that contributes to insulin resistance in muscle and liver. Clinical trials examining time-restricted eating in individuals with metabolic syndrome have shown improvements in fasting glucose, insulin sensitivity measured by oral glucose tolerance testing, and reductions in diabetes risk markers. Studies of alternate-day fasting have demonstrated similar metabolic improvements along with weight loss. These benefits appear most pronounced in individuals with existing insulin resistance or metabolic dysfunction, while metabolically healthy individuals demonstrate smaller improvements or no significant change in insulin sensitivity from fasting interventions. This suggests that intermittent fasting may be particularly valuable as a therapeutic intervention for reversing metabolic dysfunction rather than as a universal practice for metabolically healthy populations. The caveat regarding insulin sensitivity improvement is that these benefits require adequate nutrition during eating periods. When intermittent fasting is combined with severe overall calorie restriction, inadequate protein intake, or insufficient micronutrient consumption, the metabolic stress can actually worsen insulin sensitivity and glucose regulation. Some studies have shown that women appear more susceptible to glucose dysregulation from aggressive fasting protocols compared to men, potentially due to differences in metabolic flexibility and stress response systems. This highlights that the insulin sensitivity benefits of fasting are not automatic but depend on implementation that supports rather than undermines metabolic function. The second potential benefit involves weight loss and body composition improvement, though the mechanisms and effectiveness are more complex than commonly presented. Intermittent fasting can facilitate weight loss through several pathways. Most directly, restricting eating to limited time windows often reduces total calorie intake by eliminating snacking and reducing meal frequency, even when individuals are not consciously restricting calories during eating periods. The extended fasting periods enhance fat oxidation as glycogen becomes depleted and the body shifts toward utilizing stored fat for fuel. Some evidence suggests that fasting may help preserve lean tissue during weight loss better than continuous calorie restriction, potentially due to the increases in growth hormone during fasting periods. However, the weight loss observed with intermittent fasting in controlled trials is generally comparable to that achieved with continuous calorie restriction, when total calorie intake is matched. Multiple meta-analyses examining weight loss from various intermittent fasting protocols have concluded that intermittent fasting produces weight loss primarily through calorie reduction rather than through unique metabolic advantages. When calorie intake during eating windows is monitored and controlled, the additional weight loss from meal timing effects appears modest. This indicates that for individuals who can achieve calorie reduction through other means, intermittent fasting may not provide substantial additional benefit for weight loss specifically. The practical advantage of intermittent fasting for weight management appears to be that some individuals find it easier to maintain calorie restriction by limiting eating to specific windows rather than consciously restricting portions at each meal throughout the day. The structured eating windows may reduce decision fatigue and eliminate opportunities for unplanned eating. For individuals who struggle with constant hunger on traditional calorie-restricted diets, the complete absence of eating during fasting windows may be psychologically easier than eating small, unsatisfying portions throughout the day. However, other individuals find extended fasting periods extremely difficult to maintain and experience intense hunger, irritability, and difficulty concentrating during fasting windows. This high degree of individual variation in tolerability means that intermittent fasting serves as an effective weight loss tool for some people while being entirely inappropriate and unsustainable for others. The third potential benefit involves autophagy activation and cellular maintenance, though the translation of this benefit from animal models to human health outcomes remains incompletely established. Animal studies, particularly in rodents, have demonstrated that various fasting protocols increase markers of autophagy in multiple tissues, including brain, liver, and muscle. Enhanced autophagy is associated with improved cellular function, reduced accumulation of damaged proteins and organelles, and extended lifespan in model organisms. These findings have generated substantial enthusiasm for fasting as a longevity intervention based on the hypothesis that enhanced cellular cleanup through autophagy could slow aging and reduce related disease risk in humans as it appears to do in laboratory animals. The challenges in translating these findings to human recommendations are substantial. First, the fasting protocols used in animal longevity studies are often severe and prolonged, involving fasting durations and frequencies that would be difficult or dangerous for humans to implement long-term. Second, direct measurement of autophagy in human tissues requires tissue sampling that is not feasible in most research contexts. So human studies typically rely on indirect markers that may not accurately reflect autophagy activity in critical tissues. Third, the relationship between autophagy and human longevity has not been directly demonstrated, and it remains possible that autophagy upregulation is one of many cellular responses to fasting that contribute to benefits in animal models without being the primary driver. What can be stated with more confidence is that chronic overfeeding and continuous nutrient excess suppress autophagy and contribute to accumulation of cellular dysfunction, and that periods of fasting likely provide beneficial cellular maintenance through autophagy activation along with other mechanisms. However, the optimal fasting duration and frequency for maximizing these benefits in humans without incurring costs from inadequate nutrition or excessive metabolic stress remains uncertain. The evidence does not currently support extremely prolonged or frequent fasting as necessary for autophagy benefits, and moderate time-restricted eating with 12 to 16-hour fasting windows may provide substantial autophagy activation without the risks associated with more extreme protocols. The fourth potential benefit involves reduction in inflammation and oxidative stress, with evidence from both animal and human studies. Several trials of time-restricted eating and alternate-day fasting have shown reductions in inflammatory markers including C-reactive protein, interleukin-6, and tumor necrosis factor alpha. Fasting appears to reduce inflammation through multiple mechanisms, including decreased insulin and glucose fluctuations, enhanced cellular stress resistance pathways, activation of anti-inflammatory signaling through nutrient sensing systems, and reductions in visceral fat, which is a major source of inflammatory cytokines. Additionally, the metabolic shift toward ketone production during fasting may provide direct anti-inflammatory effects, as ketone bodies have been shown to inhibit inflammatory pathways. These anti-inflammatory effects may contribute to improvements in conditions characterized by chronic inflammation, including metabolic syndrome, cardiovascular disease, and potentially neurodegenerative conditions. Some preliminary evidence suggests that intermittent fasting may improve markers of oxidative stress and inflammation in individuals with conditions ranging from asthma to rheumatoid arthritis, though the evidence remains limited and requires replication in larger controlled trials. The magnitude of inflammation reduction appears modest in most studies, and whether these changes translate to meaningful reductions in disease incidence or progression remains to be definitively established through long-term outcome trials. Having examined potential benefits, we must now address the circumstances under which intermittent fasting may be inappropriate, ineffective, or harmful. The first category of individuals for whom intermittent fasting warrants caution or avoidance includes those with history of eating disorders or disordered eating patterns. The restriction of eating to specific windows and the focus on fasting duration can reinforce unhealthy relationships with food and eating, potentially triggering or exacerbating eating disorder behaviors including binge eating, extreme restriction, and obsessive food rules. For individuals with current or past anorexia nervosa, bulimia nervosa, binge eating disorder, or subclinical disordered eating, intermittent fasting represents a structured restriction protocol that may worsen psychological and behavioral dysfunction around food. Mental health professionals generally recommend against intermittent fasting for these populations, as the potential psychological harm outweighs any physical benefits. The second category includes women of reproductive age, particularly those with histories of menstrual irregularities, fertility issues, or hormonal sensitivities. Multiple lines of evidence suggest that women may be more susceptible to negative hormonal adaptations from intermittent fasting compared to men. Some women report menstrual cycle disruptions, loss of menstruation, or worsening of premenstrual symptoms after implementing intermittent fasting protocols, particularly more aggressive protocols with longer fasting windows or lower overall calorie intake. The mechanism appears to involve the hypothalamic pituitary ovarian axis, which is sensitive to energy availability and perceived energy stress. When the brain detects insufficient energy availability, whether from actual calorie restriction or from metabolic signals generated during fasting, it can suppress reproductive hormone production as an adaptive response that prioritizes survival over reproduction. This hormonal suppression may occur even when overall calorie intake is adequate, if fasting creates metabolic signals that the brain interprets as energy insufficiency. Some women can implement moderate time-restricted eating without adverse hormonal effects, while others experience disruptions with even modest fasting windows. The individual variation makes it essential for women to monitor menstrual cycle regularity, premenstrual symptom severity, and subjective markers of hormonal health when implementing fasting protocols. Any worsening of cycle regularity or hormonal symptoms should prompt immediate discontinuation or modification of the fasting protocol, as chronic hypothalamic amenorrhea and reproductive hormone suppression have long-term health consequences, including bone loss and fertility impairment. The third category includes individuals with high physical activity demands, particularly athletes or those engaging in intense training. Exercise creates substantial metabolic demands and depletes glycogen stores. When combined with intermittent fasting, the compounded metabolic stress can exceed the body's adaptive capacity, leading to inadequate recovery, loss of lean tissue, declining performance, increased injury risk, and hormonal disruptions. While some athletes successfully implement time-restricted eating by scheduling training sessions during feeding windows or early in fasting windows when glycogen remains available, aggressive fasting protocols that create substantial calorie deficits or require training in deeply fasted states generally impair rather than enhance performance and body composition outcomes. The research on intermittent fasting in athletic populations shows mixed results, with some studies demonstrating maintained performance and body composition improvements, while others show performance decrements and unfavorable hormonal changes. The critical determining factor appears to be whether total calorie and macronutrient intake remains adequate to support training demands despite the restricted eating window. When fasting protocols compress eating into windows too short to consume sufficient calories and protein, athletic performance and recovery suffer predictably. Athletes considering intermittent fasting must ensure eating windows are sufficient to meet total energy and protein requirements, which for many athletes necessitates longer eating windows than would be used for weight loss or metabolic health improvement in sedentary individuals. The fourth category includes individuals with certain medical conditions or those taking specific medications. Type 1 diabetics face substantial risks from intermittent fasting due to the need for precise insulin dosing relative to food intake, and extended fasting periods create hypoglycemia risk if insulin is not adjusted appropriately. Type 2 diabetics taking insulin or sulfonylureas that stimulate insulin secretion also face hypoglycemia risk during fasting and require medical supervision and medication adjustment if implementing fasting protocols. Individuals with gastroesophageal reflux disease may experience worsening symptoms from compressed eating windows that require consuming larger meals. Those with certain gastrointestinal disorders may find that eating larger meals within restricted windows exacerbates symptoms compared to smaller, more frequent meals. Medications that must be taken with food or that affect blood glucose or blood pressure may require timing adjustments when implementing intermittent fasting, and some medications may be incompatible with extended fasting. Individuals taking multiple medications or those with complex medical conditions should consult with healthcare providers before implementing intermittent fasting to ensure safety and appropriate monitoring. The general principle is that intermittent fasting represents a metabolic intervention with physiological effects comparable to medications in some respects, and it must be implemented with comparable caution and medical oversight in populations with existing health conditions. When intermittent fasting is deemed appropriate and is implemented effectively, several practices enhance benefits while minimizing risks. First, the fasting window duration should be matched to individual tolerance and goals rather than blindly following popular protocols. For many individuals, 12 to 14-hour fasting windows provide substantial metabolic benefits while remaining easily sustainable and allowing adequate eating time for nutritional needs. More aggressive 16-hour or longer fasting windows may provide additional benefits for some individuals, particularly those seeking weight loss or with significant insulin resistance, but they increase the risk of inadequate nutrition and hormonal disruption. Starting with more moderate fasting windows and extending gradually allows assessment of individual response and tolerance before committing to more aggressive protocols. Second, nutritional adequacy during eating windows is non-negotiable. The restricted eating period must provide sufficient calories to support metabolic function, adequate protein to maintain lean tissue, and complete micronutrient intake. Many individuals implementing intermittent fasting make the mistake of combining extended fasting with overall calorie restriction that is too severe, creating compounded metabolic stress that triggers adaptive responses, including metabolic rate suppression, lean tissue loss, and hormonal dysfunction. Protein intake should be prioritized during eating windows, with distribution across multiple meals within the eating window to optimize muscle protein synthesis. Micronutrient-dense whole foods should form the foundation of meals to ensure vitamins and minerals required for metabolic function are obtained despite compressed eating timeframes.